Morning, Kevin.
Good morning, Evelyn. How are you doing today? Thank you for showing up, and everyone else. I know that it's not always easy fitting this stuff into our daily schedules. And so for those of you who do, make an effort, I can sometimes multitask and listen and, work on other things while I do it. I don't usually while I'm attending it live, but when I listen to a pre-recording, I can sometimes multitask. And so I appreciate y'all being able to multitask and letting this be one of your tasks. We always are excited when folks show up and celebrate each other's sort of presentations and sharing of what they want from their research, essentially. So this is our second day of the colloquium. This is colloquium week, and yesterday we had a panel discussion on the topic of pleasure. And today we move into the topic of cultural competence and sensitivity. And we have two presentations today. The first one will be with Dr. Marzilli. Dr. Marzilli has also done a speaker series on cultural competence. And today she's going to focus on some research related to the cultural competence of pre-licensure nursing students in the programs. That's where she teaches over in Austin. So Colleen has a whole lot of background in the pre-licensure world and also on the topic of cultural competence. And now she's blended those two into some research that she's going to share with us today. So Dr. Marzilli, I'll get out of the way and let you just take over.
Well, thank you so much for that wonderful introduction. I appreciate you, Dr. Thrasher. So I am talking to you guys today about cultural competence in pre-licensure nursing students. We're going to discuss the level of cultural competence in pre-licensure nursing students, discuss demographic variables that are predictive of cultural competence, identify opportunities to prepare students to meet the challenges of preparing for a culturally diverse patient population. And so I truly believe that the importance of cultural competence is that with all of the events that we're seeing, starting in 2020 through today, there is an increased focus on belonging. And whenever I like to talk about things like belonging, justice, equity, diversity, and inclusion, I always like to use the mnemonic Be a Jedi. So Be a Jedi is B for belonging, A for allyship and advocacy, J for justice, E for equity, D for diversity, and I for inclusion. So I like that kind of way to think about cultural competence as kind of an all-encompassing term for these issues that we're really struggling and have been challenged to address in the 21st century, especially in areas like healthcare, business, education. These are so important. I also want to stress the importance that attention towards proactively ameliorating causes of health disparities can be underpinned through concerted efforts in addressing cultural competency. So this is the abstract. I'm not going to read that to you, but that was included in the colloquium information. Again, my name is Colleen Marzilli. I obtained my PhD from the University of Texas at Tyler. I obtained my DNP from the University of Tennessee Health Science Center in Memphis. I have a couple of board certifications as a med-surg nurse, case manager, public health nurse, nurse educator, nurse executive, and family nurse practitioner. My hobbies include traveling, running, and making those decorated sugar cookies that people always have at parties. So I like to do that. It's kind of my therapeutic outlet. So my background for this presentation, it's important to note, and you probably know this, but over 40% of the US population is considered to be from a minority background. In different parts of the United States, that number is even higher. Where I live in Texas, it is actually higher than 40%, and Texas is one of those states that is a minority state. So the majority of the population is actually comprised of what are considered to be demographically minority. Approximately 30% of healthcare employees are from diverse backgrounds. And so you can see there's a mismatch between the healthcare employees that we have and the population that they're taking care of. And then about 15% of healthcare leaders are from diverse backgrounds. So you see that, the frontline workers, the frontline caregivers a little bit more closely match the patient population that they're providing care to, but those that are leading and in decision-making roles are extremely different than the people that they are making decisions that affect. So the significance, as I mentioned, with the events of 2020 through today, we see that issues like justice, equity, diversity, inclusion, belonging, advocacy, allyship, these are coming to the forefront of what we're doing in professions like education, business, healthcare, and we have to make sure that we're preparing our students well so that they can go out into the workforce and take care of patients, interact in business environments, that they are able to teach their future students in a way that is congruent to their cultural needs. We have the Patient Protection and Affordable Care Act. That's been the law of the land for, well over a decade now. And we see that there are a lot of pieces of that Affordable Care Act that speak to addressing health disparities. My concern is that unless we are able to meet patients where they are in a culturally competent manner, we aren't truly going to be able to reduce those health disparities and provide care that speaks to what is intended with the Patient Protection and Affordable Care Act. Here's a little bit more information for you. So approximately 71% of nursing students are white. Cultural competence curriculum was first written in 1986. We have that in nursing, we have that in medicine, with their essentials for professional nursing practice of 2021. And domain 3 specifically addresses population health. When you look at the sub-domains for population health, what we see there is language that addresses things like what we're talking about when we talk about cultural competence. So it's extremely important that we're able to understand how this fits into the nursing education that we're providing. There is a lack of data regarding existing level of cultural competence in students. There have been studies that look at this. There are some that are quantitative. There are different instruments that can be used to look to use. And so that's a barrier for that information to be translated into practice. And so what I am going to talk about with this study is in a manner that's not cost prohibitive for researchers to use. Student perceptions of individual cultural competence are not well documented. So when some of the qualitative studies look at cultural competence, they fail to capture what students actually think of cultural competence. And I like to give this example of talking with a student about cultural competence, and they talk about how they provide care to all their patients in the same way, according to the golden rule. And if you've heard me talk before, you've heard me talk about the golden rule, do unto others as you would have them do unto you. And that's one of the easiest ways for us as healthcare professionals, as nurses, to interact with our patients and treat our patients, is to treat them how we would want to be treated if we were the patient. But the problem with that is that when you have that mindset, it doesn't take into consideration the cultural values of that individual person. What they desire and what they need from a cultural standpoint may be completely different from what you would need and desire. So it's better to operate from the platinum rule, where you are basically treating people how they need to be treated or how they want to be treated. And so the literature is ripe with information about cultural competence. A lot of it centers on medical conditions, looking at different disease processes and the implications for cultural competence related to that disease process. Or if you have a patient that has Tay-Sachs disease, it is genetically in this population, and here's how you would respond to that particular population or segment of the population. One of the things that comes up often when looking at cultural competence is HIV care and providing care in a culturally competent manner for patients that have HIV. And then mental health. I find this one really fascinating because there's a lot of taboo, a lot of cultures consider mental health to be very taboo. There is research that looks at culturally competent manner of dealing with mental health and providing care to patients suffering from mental health. And then also access to care, looking at how patients perceive their desire to seek care or barriers to them actually receiving. Competence. And so that brings me to my research question. What is the level of cultural competence of pre-licensure nursing students? And so I'll talk with you about that in my instrument that I'll discuss. Are there differences in cultural competency scores of pre-licensure nursing students based on demographic variables? Is there a way that we can say this student might have more of a gift of providing culturally competent care than maybe this student, and maybe this student needs a little bit more time than this student in learning things like cultural competency? And I'll go into that. What are the perceptions of pre-licensure nursing students towards cultural competency? Because again, I think that's so important to understand what students actually think of cultural competency. Is it something that they think they're already doing because they follow the golden rule, or are they truly seeking to provide care? So hypothesis, pre-licensure nursing students are minimally culturally competent. The demographic variables of English as a second language, number of languages, and traveling abroad are predictive of higher levels of cultural competence. And then the third hypothesis is that pre-licensure nursing students have a desire to learn about cultural competency. So this sample used 100 pre-licensure nursing students. They were recruited as a convenient sample at a local nursing school. The students had the option to participate in a qualitative interview. A priori power analysis indicated a need for at least 89 participants, which was met. So the theoretical framework of this study is Kempina Bocote's process of cultural competence in the healthcare system. Her theory looks at cultural awareness, cultural skills, cultural knowledge, cultural encounters, and cultural desire. And the instrument that I chose is an instrument that this is the first time that it was, well, when I used it back in 2005, it was the first time it had been translated into English. And so I've used it a couple of times since then, but this is a 41 item survey with 4 subscales. It looks at cultural awareness, cultural knowledge, cultural sensitivity, and cultural skills. And so this does mirror Kempina Bocote's theory. And to give credit to those researchers that developed this instrument, they're out of Taiwan, and they're Drs. Pern, Glenn, and Chuang. Looking at the demographics, general standard demographic information was included, like age, gender, education. Also measured cultural items like, have they traveled abroad? What sort of encounters do they have with patients of diverse cultures? Do they work in healthcare prior to admission into their pre-licensure nursing curriculum? Do they live in an area that borders another country? How many languages do they speak? Is English their second language? And then there were 3 questions that specifically looked at desire that I developed. So the methodology for this is a convergent parallel mixed methods design. So it did have both quantitative and qualitative strands, which I think provides such a rich piece of information when you're looking at both the quantitative from the instrument and then the qualitative from the interview process. So cultural competence aspects of care can be triangulated by using both quantitative and qualitative methods. And I think that's really the beauty of what we see when we looked at mixed methods data, is that what we see in quantitative informs the qualitative and vice versa. So the setting for this is that it was conducted online for the quantitative portion. So it was an online survey that students completed at their convenience. The setting for the qualitative portion was conducted over the phone. And so this was, we were still worried about COVID. It was difficult to meet with some individuals face to face. So this the interviews were conducted over the phone, which actually worked really well for the students. And I was a little concerned about that at first, just because my experience with some of our younger nursing students is that they don't necessarily want to talk on the phone ever. And so I would
Colleen, you kind of cut out on your audio there. I don't hear you any longer. I don't know if others are experiencing the same thing. It looks like Evelyn said she can't hear you either. Maybe reception. Can you hear us, Colleen? Okay, it looks like Colleen dropped off. Let's just hang on a second. She'll reconnect. Thank y'all for your patience. She's in Texas, so I know she's not experiencing cold weather. They got good weather over there compared to other people. Evelyn, you're up in New York, if I recall, so I'm sure you're ready for the springtime to hurry up and get here.
Yes, I am. No more snow in Maryland.
Yeah, I hear all kinds of crazy stuff. It looks like everybody's at least getting in the 70s, even up in Chicago today. They may get that warm.
Definitely. Beautiful. Spring weather is on the horizon.
Yeah, the only problem with that is it makes you have to mow the lawn. I'm gonna pause recording until Colleen can jump back on. Y'all can just hang out, but we won't be recording.
Okay, perfect.
Okay, everyone, we're back. Dr. Marzilli, you can begin.
Okay, thank you so much. Sorry about the technical issues. So to restate, this was IRB approved. Qualtrics was used for the quantitative portion of the survey. SPSS was used to analyze the data from the quantitative survey. With the qualitative portion of this study, this was a very time-consuming process. So the interviews were recorded with permission from the participant. And after they were recorded, they were transcribed and coded. I'm sure there's a software out there that will transcribe recordings for you automatically, but it was a little bit more in my comfort zone just to do it the old-fashioned way. So I did that. There's also many different programs that help with qualitative data to code your data and assign themes, but I prefer to do that, again, the old school way and identify my own codes and themes that appear in the data. So data was triangulated using investigator theory and methodological triangulation. And so the results of the study, the quantitative strand, statistics used, we had descriptive statistics looking at the mean and standard deviation. This was calculated for each of the 4 cultural competence subscales and the overall level of cultural competence. So each subscale had a number that was assigned to it as a total, and then the 4 subscales were added together for a total that provided the overall level of cultural competence. These were analyzed using Spearman's Row to determine demographic variables that have significant relationships to cultural competence. These variables were analyzed using one-way ANOVAs for the variable of language spoken and when cultural competence education was obtained. So had the students heard of cultural competence before? Had they had a class on it? Maybe in high school, maybe in some of the training that they received if they were working in the healthcare setting as a tech. Also looked at descriptive statistics for the demographics to describe the population to give a better understanding of what that population looked like. Now, the qualitative strand, this was evaluated using the constant comparative method. Again, these were transcribed and then reviewed to identify themes. Constructs and examples of the constructs were used to support each theme. And trustworthiness was established with member checking, keeping a field journal, and triangulation. This followed Strauss and Corbin's method for qualitative data analysis. So the results of the study, well, cultural competence scores range from 81 to 197. And so the 81 was actually an outlier. And so when I evaluated the data, I took that outlier out, and I also had the outlier included. So I ran the data both with the outlier and without the outlier. And there were some very interesting things about the outlier, and I'll go into that. But the number of language spoken was significant. So people that spoke 3 or more languages was predictive of cultural competence. 2 or more language were more culturally competent. So speaking 2 or more languages was predictive of cultural competence. So this looks at some of the results from the qualitative strand. So the 3 themes that really stood out were knowledge is experiential. We had skills require emotional intelligence, meaning that cultural competence is something that can be learned. Just like when we think about knowledge is experiential, the more often that someone is able to experience that and work with patients from different cultures, the stronger their cultural competence level is. And then also desire stems from a catalyst. So the sub-themes for knowledge is experiential include distinct cultural differences in experiences, and then differences in populations, as well as ethnocentrism. So some of the examples from the qualitative literature included caring for her mom patient, change in student inter-patient population, and then again, ethnocentrism was something that really stood out. It gets in the way of students seeing the value in others. This idea of cultural superiority can get in the way of cultural competence. And I think that makes sense. Also, when we talk about knowledge as experiential, we have education. So education examples focus on experience. And again, this is something that's really important to consider when we look at something like a nursing curriculum. We want to make sure that we have clinicals or learning activities that are built into the curriculum that provide these experiences. Skills require emotional intelligence was another theme. Under this theme was cultural competence, accommodating, and modeling. When we look at cultural competence, definition focuses on the needs of others. And this goes back to the platinum rule. And that is a little bit of a paradigm shift when, for a lot of us, we grow up with the idea of the golden rule, do unto others as you would have them do unto you, and shifting that focus to, I will do what you need to honor you as a patient. So accommodating was something else that emerged as a sub-theme, making trade-offs or breaking the rules for the other. And so accommodating can be a very valuable tool that was discussed in the qualitative strand when asking students about what skills, what sort of emotional intelligence, and then modeling, showing through actions how to care for those that are different. Students talked about observing preceptors, observing faculty members, observing different nursing staff, modeling behaviors that supported culturally competent behaviors, and this emerged as very important in the qualitative data analysis. And then the last theme was desire stems from a catalyst. So the sub-theme of desire was really important, and it linked to an individual thought or attitude that causes the individual to buy into caring for the other. So there must be a desire to be culturally competent, that was very evident from the interviews with the students. And the one outlier when asked about desire, the attitude was one of, I don't need to do that. This is stupid. I don't know why you're talking to me about this. Why does it matter if someone has a different cultural background or a different set of values? Why can't they just come and follow the rules in our healthcare setting? And one of the things that really stuck out when talking with a student is the student said, if they want to come here and get health care, they need to do what we say. And so to me, that was really important because when we think about nursing and we think about what it means to be nursing and to provide nursing care, that's not the attitude or the mentality that we want to approach our patients with. So it's very important that desire is there for cultural competence. So respondents scored higher in awareness and sensitivity. And I think this really speaks to where they are in life and where they are in nursing school. So these students have not had a lot of clinical experience at this point in time. Now, some of them have worked in hospitals as a tech or as a nurse aide, but they don't have a lot of experience working with patients. So the idea of skills and knowledge being lower really made a lot of sense because they had lack of exposure. They weren't in the hospital all the time. They weren't working with patients all the time in the clinic. Some of these students were fresh out of high school, had never really worked a day in their life. And so their world was very small, consisting of their high school teacher, their friends, and their parents. And so when they get to nursing school and have done their prerequisites, which some of them had done their prerequisites actually in high school, so they truly were straight out of high school, they have a definite gap in experience dealing with people that are different than their little microcosm. And so what emerged was this idea that these students a lot of them are very aware of these issues like justice, equity, diversity, and inclusion. Their friends talk about it, even though they may not have the experience actually doing it, it's something that they talk about. And so they scored higher in awareness and sensitivity, which is extremely promising to me because in my opinion, those can be much more difficult for students to learn. So their heart's in the right place. They're aware of this need. And skills and knowledge, well, that can be taught through experiences, through curriculum. I thought it was really interesting that number of languages spoken was predictive of cultural competence or a higher level of cultural competence. And that makes sense to me because it means that they may be used to going back and forth between two different cultural groups. Maybe they speak one language at home, and then when they're at school, they speak a different language. So they're making these shifts all the time between these two worlds. And there is some literature that talks about this a little bit more. So it is supported in the literature, this idea of number of languages spoken as predictive of cultural competence. Campino-Bacote's model recognizes the idea of encounters. And when we think about that, it really reinforces what we saw with this data in that skills and knowledge are lower because they had less encounters or no encounters. And then of note, the outlier did not express desire to provide culturally competent care. And I think that quote that I shared with you really exemplifies the lack of desire that this one student had. So what does this all mean? Well, I think that I have a lot of hope in what I found in this particular data set. To me, what this means is that nursing faculty members serve as role models for cultural competence. A nursing faculty member plays a key role in socialization for nursing students, plays a key role in making sure that students are provided diverse learning opportunities, making sure that students are aware of larger issues, and making sure that things like the AACN essentials are included in the curriculum. Cultural competence is a journey, and I think that's really important. So often what we see is that people want a one and done approach. We want to be able to check the box that we're culturally competent and move on. We want to, cross that off our task list and move on to the next thing. But cultural competence is a journey. It's not something that you can check off a list. It's continual development, it's continual growth, it's continual learning, it's continual progress along the way. And when you look at cultural competence as a continuum, think that really speaks to the importance that as we grow and develop as professionals that are aware of things like cultural competence, that we move from being unaware that we're culturally incompetent, and then over time we become unaware that what we're doing is culturally competent because it's second nature to what we do. And then education programs should give authentic experiences. Some of the literature looks at travel studies. They look at 1 week little experiences for students, and I don't discount those at all. I think they're a really great experience for students to have, but the literature talks about how in some ways it can be damaging to the student to have an experience like that where they're immersed in a different culture for such a short time as of 1 week, because in a lot of instances, it will highlight stereotypes rather than giving an authentic learning opportunity for the students to truly immerse themselves in that culture and understand a lot more of the subtle nuances that we see when talking about culture. Educational experiences should engage and create desire. We want to make sure that we're harnessing our students' thirst for knowledge and their desire to be professionals. We want to make sure that we're harnessing that and we're leveraging it so that they have an experience in their nursing education that provides them with these opportunities for engagement. I think as we look at best practices for teaching cultural competence, the literature review is really important to make sure that we understand what the current literature says. And keeping up with evidence-based practice is something that is very, very time consuming. And as busy educators, we don't always have time to keep up with best practices. But when we're looking at things like curriculum, and we're making these important decisions, we have to be aware of best practices for things like teaching cultural competence. We also want to make sure that we understand policy recommendations. If we're creating policies, if we're looking at policies that have been mandated by the federal government about health and equitable access to healthcare, how are we making sure that our students are aware of that information? Because policy does have an impact on culturally competent care. It does have an impact on access to care. It does have an impact on reducing health disparities. And our students oftentimes are intimidated by policy. And so as faculty members, it's important that we're able to parse those policy recommendations down for them so that they understand what that means to their practice as a novice nurse. So, questions unanswered. Well, in my sample, there were very few men. I only had 4 male participants out of 100. So 4% is pretty concerning. This was limited to an area in Texas. So what about other areas of the country? Again, Texas is a majority minority state. So the majority of the population is representative of a minority. What about areas that don't have majority minority status? How is this taught in nursing? How are different schools teaching cultural competence in nursing? What are the implications for the new AACN? That is not 2921, that is 2021, Essentials for Professional Nursing Practice. And how do we consider the implications for Domain 3, which I mentioned at the beginning of this presentation, I think is so important as we consider the future of nursing and what that means for our nursing students. But these are some of the unanswered questions that I have, really doing a deep dive into how different nursing schools are teaching cultural competence and the issues that go along with cultural competence, justice, equity, diversity, inclusion. When you look at cultural competence as a word, there are other terms that researchers use, like cultural sensitivity, cultural awareness, cultural humility. And these all have slightly different meanings. But when I look at them, I really interpret them as being synonyms for cultural competence. And yes, there are different flavors on each of those terms. Cultural humility specifically addresses the need to be humble before other cultures. But when I look at cultural competence, I really see it as an umbrella term for these other terms. And I see that justice, equity, diversity, and inclusion are a natural fit talking about cultural competence. And I think it's important to understand, how is this being taught? Is it being threaded throughout the curriculum? Is it being put in a concept-based curriculum? Is it being taught in one class? Some nursing schools will even include this as an elective. But what are the results, and how do they know what they're doing is successful in addressing this important issue? So future explorations, I do think it's important to have a larger sample. I think it's important to have a more diverse sample. So only 4 male students. The majority of the sample was white. I would love to do this with Aspen students. I would love to see if there's different students with online versus seated nursing programs. Is there a difference in how this is being taught in different modalities for teaching nursing education? And then I really think it's a worthwhile endeavor to look at, with different schools interpreting the AACN 2021 essentials in different manners, how are they tackling cultural competence as part of Domain 3? So again, I just want to restate the objectives, discuss the level of cultural competence in pre-licensure nursing students. So these students were moderately culturally competent, where their strength really lied in their desire, in their awareness, and their areas where they could definitely improve that number was in knowledge and skills. Demographic variables that are predictive of cultural competence, language really stood out as the #1 predictive value. And those that spoke 2 or more languages was predictive of higher levels of cultural competence. I think that when we look at objective 3, identify opportunities to prepare students to meet the challenges of preparing for a culturally diverse patient population. I think that there are a lot of challenges that our students face. And part of that's curricular, part of that's experiential. But I think that's also encouraging because we can include those in our curriculum. We can include those in our experiences for our nursing students. So takeaways, cultural competence must be taught and it must be intentional. We need to include elements that speak to belonging, advocacy, allyship, justice, equity, diversity, and inclusion. These are the terms that our students are comfortable with. These are the terms that our students are familiar with. When we talk across disciplines, when we talk to people in business, when we talk to people in education, they are aware of these terms as well. They are aware of belonging and how important belonging is. They are aware of advocacy and how important that is. They're aware of these issues of justice. And I think more and more of the population as a whole is aware of these issues of justice, equity, diversity, and inclusion. Nursing has done a lot of great work in trying to improve these areas of health for all in the United States and in nursing. Specific programs targeted towards increasing the number of people of color in leadership roles. Leadership institutes designed for people of color, working to have inclusive language for LGBTQ individuals, making sure that our textbooks have pictures of people that look different in them. And one of my dear colleagues that I worked with in the past, when she went to school, she was the only African-American in her nursing school. And she talked about how in nursing school, when she was reading the book, there were no nurses that looked like her. There were no patients that looked like her. They were all white. And that was very difficult for her to consider how she fit into nursing as a professional when all the images that she saw did not represent her. And I think that's really important. For me, when I hear stories like that, it's very telling of how important things like words and pictures do matter, not only for our patients, but also for our students and our fellow colleagues. I also think that it's important to consider how we provide students with meaningful opportunities to experience working with diverse patient populations. This is so important, and it can be challenging. We know that clinical space is limited. We know that clinical opportunities are limited. And so sometimes having an experience for a diverse patient population is a little outside of the box thinking. Maybe when you're doing high fidelity simulations, instead of purchasing the white mannequin, the African-American mannequin is pictured, or the mannequin with dark skin is pictured. Maybe it's having your simulations that you're running with students have specific language addressing the Hmong patient or addressing the patient that came from Cambodia. In Texas, where I live, we have a very large population that is Hispanic. And using terms that they would use, talking about hot and cold, or mal ojo, or the bad eye, is something that can be included in these simulation experiences that includes a meaningful opportunity to think about a diverse culture. And so that is a little bit outside of the box thinking, but I think strategically that makes a lot of sense, because it's changing something that can be controlled. I'm not going to say easily, but it's changing something that you can control as a faculty member. You can have inclusive language in simulation opportunities. You can have inclusive language in different scripts that are being used in different patient scenarios. Whereas clinical experiences can be extremely difficult for faculty members to locate opportunities and situations and settings where that can occur. So with these key takeaways, I think that it's really encouraging for thinking about the future of cultural competence, thinking about the future for our nursing students as they go from being novice as brand new nursing students to experts in that professional role that we want them to have and that we want them to thrive in. So real world implications, this is not limited to nursing or healthcare. In fact, it's not limited to education or business, like I mentioned as well. This is something that is on the national news. This is something that's in global news across the world. When we look at things like justice, equity, diversity, and inclusion, these are issues that affect all. And as nurses providing care to those in their most vulnerable state, it's a beautiful opportunity to provide the patient who is extremely vulnerable in their health crisis. It's a beautiful opportunity to provide care to them in a way that honors them in respect to their cultural background. So again, the Be a Jedi, belonging, advocacy, allyship, justice, equity, diversity, and inclusion initiatives are the focus of many professional development topics with the events of 2020, 2021. I can't tell you how many emails I get a week talking about Jedi initiatives, and I think that's really valuable. And I think that as nursing professionals, it's an opportunity for us to talk about how we're doing that in healthcare to reduce these health disparities that our patients are struggling with. And then cultural competence is an inclusive term to address the professional qualities essential for global success in the 21st century. And when I think about my skills for success in the 21st century, I talk about cultural competence. I also talk about three others: leadership, communication, and caring. But cultural competence is one that I always put first and foremost, because we live in a global society and we have to be able to work well with others. Just like we were taught in kindergarten, we have to be able to work well with others. We have to be able to work well with others now. And I think that's so important. So let's continue the conversation. I do have time for questions. I'm going to turn it back over to Dr. Thrasher. If you would like to email Marzilli at aspen.edu and my phone number.
Thank you, Colleen. I appreciate you hanging in there through the technical difficulties. And I appreciate everybody else hanging out. I think the conversation, and I always like how you end it with, let's continue the conversation. In other words, there's more to talk about. You know, you can continue to peel back. Every time I sit in your meetings, my brain just is, you know, very active on so many other sort of domino thoughts that springboard off of comments that you say. So I do appreciate you reminding us about Be a Jedi in terms of justice, equity, and diversity and inclusion. And then also the platinum rule. You've mentioned that in your speaker series that you gave on cultural competence, where, you know, the golden rule is do unto others as you would have someone do unto you. But the platinum rule is do unto others as they want you to do unto them. In other words, you're taking their perspective on how they should be treated, not saying I'm going to treat you like I want people to treat me. You know, that's me treating you like I want to be treated, as opposed to treating you like you want to be treated, which I think is a very important concept that I had never heard until you introduced that. So I appreciate you bringing that back up. The good thing from your research is, for the most part, people are doing okay in this area, and it can be taught. I thought that was a very important comment that you made, that if some folks have less competence, cultural competence, that they can, through experience, you mentioned, in curriculum, obviously, if they're in a program like a nurse or something, can be taught to be more culturally sensitive and competent about, and even with their behaviors and comments, which I think is probably what they may not realize that they may be doing that's offensive to others. And then I recently heard about cultural humility. I think that's an interesting concept, where you have to somewhat, you know, be humble about your own culture in order to understand the perspectives of others. And I'm sure in some way egocentrism mixes in with that, where I can't see others because I can only see it from my view. But if you're humble, then maybe it allows you to see others. But I also did have one question. I think when we talk about cultural competence, and I might not always be using the sociological terms correctly, but I do recall from a sociology class that there's macro cultures and micro cultures, right? There's a dominant mainstream majority culture, and then there's a subculture or subcultures, let's say, and minority cultures, etc. And I don't always want to think of majority and minority in terms of race, but it is sort of the majority. It does correlate with race in America, at least, where the majority culture, the mainstream culture, is the European Anglo white sort of view of the world. So my question is, when we always talk about cultural competence, it does seem that we're always saying, you know, that the Anglo folks are the ones that need more cultural competence, that they need to be working on being, you know, more sensitive to other cultures. And I'm just curious, is there any research out there that examines how the subgroups have cultural competence towards other subgroups? Or is it always only the dominant? You mentioned almost everybody in your, you know, study was white. How different would that look if it was the folks who are typically not being treated in a sensitive way, to also see, do they exhibit or possess some of these cultural competence characteristics that you mentioned? So just food for thought, but, you know, it does seem like it's almost always on one population, mostly Anglo, but how much does cultural competence interact?
Well, and Kevin, this is Nina. Let me expand that a little bit, because I think all of you know that I have a grandson who's on the autism spectrum. And I saw something on Facebook where it says, you know, we're working very hard to get him to fit into the neurotypical world, but we aren't doing much to teach neurotypical kids how to fit in with them. And it almost seems like both groups need to have similar cultural humility. Would anybody like to comment on that from the educational standpoint?
Oh, I can talk a little bit maybe about the field of education. I do know, and I was thinking about this as Colleen was mentioning, that some of it's curricular, and that is within the field of education, whenever you're training to be a teacher, there is the requirement that you are required to be exposed and do student teaching hours with specific diverse populations. They require that as part of your exposure. You have to do X number of practicum hours with specific populations. Now, I know in nursing you might have something similar, but it seems to be more like you got to go do peds, you go do mental health, you go do maternity. It's more of a topical exposure in terms of hours, and I'm sure there's a diversity class and stuff in there. Whereas within education, it seems to be more blended into everything that you do, that you have to take into consideration the student whenever you are considering their education. And it's the same within medical field. You have to take into consideration the patient in order to apply the, the medical intervention. I don't know if that answered your question totally. I don't know if they intentionally teach cultural humility and so forth in education nowadays. But I do know that there is a huge focus on being very aware, especially second language learners, has a lot of influence, bilingual education, on us being more aware of culture. And when we think of bilingual, where I live in Phoenix, by the way, there's an elementary school that is, I don't know, it's 1.5 miles or 2 miles from my house, and they speak 23 languages.
Oh, wow.
In that elementary school. So we often think of Spanish because, again, I'm in Arizona, it's very close there. And yes, the majority of people who speak a second language are speaking Spanish. But there are also 22 other languages, mostly refugees from places around the world. They seem to migrate here in Arizona. I don't know why, but we have a high population of African and Arab refugees as well. So anyway, Nina, it is built somewhat into our curriculum. We're sort of we have to do that. Now, I don't know to what degree just because I make you go be exposed to people doesn't mean you change your attitude about them. So it doesn't mean you're going to be culturally competent just because I make you go do 10 hours of work with, children who are second language learners. Like Colleen said, there's going to be some people with the attitude, you come here, you need to do what we say. And I know they probably mean that in a good way. I don't think they mean in a bad way. It sounds horrible, right, when we hear someone say that. But I think what they maybe meant to say is, we need you to follow our medical advice so that you can get better. And I think it may have been what they meant, but the approach is the opposite maybe of the approach of their culture. The approach of their culture is not jam stuff down their throat and authoritarian. The approach of their culture maybe is you got to bring their family in and convince their family and get mom and dad's approval to say, yes, we'll go do this procedure, as opposed to you need to do it the way we say it. So I think that's where the cultural competence piece comes in. And I also believe in terms of what Colleen said, that a lot of it can be done through simulations. But I don't know to what degree the simulations even feel artificial. Just because you call someone Juanita in a simulation doesn't make it multicultural. You know what I mean? And just because you say we were at a cumpleaños, doesn't all of a sudden make it multicultural. So that's my only comment sometimes about what we try to do with throwing some cultural, ethnic names into stuff, and then all of a sudden say that that's cultural. Anyone else who wants to talk about this topic? This is really interesting. I think it impacts so much of what we do on a daily basis outside of our professions. It's hard not to interact with someone who doesn't have some different culture at one point in time, even if it's a subculture. I interact with the younger generation, and I feel like they're a different culture sometimes. I'm like, I just can't relate to what they understand and value.
I went to nursing school in New York City in the 1980s and 90s. I was the only Hispanic young lady and another African-American girl, and yes, majority white. And we had to educate and teach sometimes students about cultural sensitivity, because you would hear comments like, oh, they might be from, let's say, India, and says, how come they've been here for 20 years, they don't know the language? And I would just look at the student and say, maybe because it's difficult at a certain age to understand, to learn the language. And sometimes there's a comfort level when your family member comes and explains things a little bit better or different than what the doctor's saying. So, I would not get angry. I would just more take that time to educate my colleague. And then once they saw the interaction with the patient and the family members, they understood why is it the patient felt comfortable to disclose more information while the family was around, opposed to us or the doctor. So yeah, it takes time. It takes I think that we've gotten better be more in the forefront. And I see it in the practice now when I'm working in nursing as a nurse in school or in the hospital setting, the VA, it's getting better.
Yeah, I always hope over time, exposure to each other allows people to break down whatever barriers they have to each other. What I've often noticed is if you get around anybody, it doesn't take long before now all of a sudden you don't dislike them anymore. You know what I mean? It's like, now that I know you, I kind of like you, and I think sometimes people's, distance from a culture is there's a fear of that culture. And so we want to distance ourselves from things we don't understand. The fear is just because I don't understand. It's not because they're dangerous necessarily. Well, Evelyn, congratulations for you helping take the right path, because I think in your scenario, many of us can never comprehend that. I often think I've always grown up in a white world. I'm always around people who are white. I'm always in a space where I look around, I just see more white people in the majority of the time, depending on, what area of the city I may go into. But I've never really felt like, dang, I'm the only other person in here, except when I go overseas. And so like when I went to India, I mean, real quickly, it was like, ooh, man, now I know what everybody else feels like. Now I know what, a Black person or maybe a Hispanic person will feel like all of a sudden in a gigantic crowd of white people. When you're in the white crowd, you don't feel like the Black person or the Hispanic person necessarily is an outcast. I don't never notice that stuff. But from their perspective, they're something floating around in a sea by itself, and they probably feel like all the eyeballs are looking at them, because that's the way I felt over in India. Everywhere I went all the time, I was the only one. And everybody stared at you. And I mean, they would literally come up and take pictures and stuff of you and just look at you because you were so different. And
But Kevin, the best way to find out about another culture is not to read the NCLEX review books.
Yeah.
The best way is to ask a person exactly what she said. How would you like to be treated? Because again, I think people are a mix of cultures and people are unique. And so I sort of hate the NCLEX review books that say that, all Black Americans eat fried chicken and collard greens and, let's stop pigeonholing people and say, hey, whatever culture you happen to be from, how do you want to be treated? I mean, I thought she made a really good point. We don't want to start rubber stamping cultures either.
Yeah.
And saying, this is how this person wants to be treated.
Can you ever use that in a non-negative way? And for example, if we say a specific culture may eat more fried foods than other cultures, and we know there may be certain types of diseases that could exist in this culture because of their eating habits, and other ones like maybe Asian or Japanese, they don't eat fried foods, and therefore they may have different types of medical treatment. So I mean,
but even if that's true, that doesn't mean that the person in front of you is the representative of that culture. Yeah. According to the book. And that's what I'm trying to say. Let's talk to each other as individual humans, because that person may have decided to go against their culture and eat differently. Who knows?
Absolutely.
By the way, I love fried chicken. Y'all know that I'm from Kentucky. So that little stereotype doesn't fit with me. So anyway, good comment there, Nina. I do think, again, culture, how you approach it is important, because we have to remember those on the other end may not always have lived the same life you did, being in a different culture, and how you see the world. Any closing comments, Colleen?
No, just that, well, yes, just that I think that this is such an important topic. And you did bring up a good point, Dr. Thrasher, that a lot of the research does look at the majority culture as the one that needs to change. But there is an opportunity to look at this in the reverse perspective, kind of like Dr. Beeman mentioned. And so I think that there's lots of opportunities for future research. There's research out of South Africa that looks at the white population as minorities and their experience being in that culture and how things have their experience in that. There's also research that looks at strategic initiatives to increase minority representation in different facilities with the idea that would increase or improve health outcomes for minority populations. And when those initiatives were evaluated, it didn't show the promising results that they had thought. And so that's another thing to think about is I believe that diversity is extremely important and representation matters in and of itself. But when people are saying this is going to fix all the problems in healthcare, I think that also is an opportunity for us to do future research to look at, is this really the magic bullet? You know, because we love a one size fits all approach. We love a magic pill to fix things. Is this the magic pill to fix things? Is increasing minority representation to improve health outcomes in our population? Is that actually what's happening? But again, I'm not saying that diversity programs to increase minority representation aren't valuable. I believe those are valuable in and of themselves, but we also have to look at, are those programs doing everything that they're going to say with improving health outcomes in the United States?
And I believe, if anything, the most important thing to also do is to keep the conversation going, right? And I don't know we'll ever reach a point where we say we are culturally competent. Yeah, I think we'll always be in this continuous development process because culture will change, you know, so whatever you think you're competent in, you'll need to be recompetent, you know, on modifications and how cultures morph over time. You know, more cultures are living organisms. They're an entity in and of itself. And so they're affected even by social media things, you know, and that old culture now all of a sudden, we learned this morning also culture is affected by the fairy and folk tales that you are brought up on and how that indoctrinates your way of thinking of the world, you know, on certain approaches and certain belief systems. So it's almost impossible to escape the topic. You know, it impacts us everywhere, and it may impact us more in the US because we have a more culturally diverse population than most, but that's not even true nowadays, really, you know. So anyway, for those of you who want to also learn a little more about cultural competence and sensitivity in education, we do have in 2 more hours from now our next presentation for day 2 of the colloquium. And Dr. Cam will be giving that presentation, and she's lives in Hawaii. And so the culture that she will be examining will be the Hawaiian culture, and how being sensitive to that culture in your educational approaches reap greater benefits for students who are from that culture when you recognize their culture and help them belong in the more mainstream culture. So we hope we'll see you on a couple of hours. I will record, I'll send the recording around from this meeting today and a summary, and we'll see you here soon. Talk to you later. Bye-bye.
Thank you.
Stay safe.
Have a great day.
Bye-bye.
Bye-bye.